can address us.
Photographers are taking my photo. We'll manage. I have to confirm. Yeah, they are. This one? The one that was not moving yesterday. Good morning, ladies and gentlemen. My name is Dr. Simon Kigondu. I'm a politician. But by training, I'm a gynecologist, obstetrician gynecologist. And this morning, I'm going to talk about medicine. Hello. This morning, I'm going to talk about medicinal technologies and sustainable health services in Africa. With the vibe on universal health coverage, I think this is a very important topic. The basis of my presentation is not the usual scientific kind of presentations. It's based on my leadership at Kenya Medical Association, my service in the public health sector, for which I currently work in Murang'a County Referral Hospital. I've previously been a medical superintendent at Isiolo District Hospital, for those who know where that is. I'm also in private practice. We do part-time private practice at the KMA Center with my group practice team at Hercules Healthcare. Kenya Medical Association is a voluntary membership association. It is for medical and dental practitioners, but it has associate members, nurses, clinical officers, and others. The only difference is that the associate members don't vote. So medical and dental practitioners. It was founded in 1960. This year we had our Golden Jubilee celebrations in Mombasa. And its twin mandate is doctors' welfare. And in this talk, quality healthcare for all Kenyans is where the Kenya Medical Association touches on. This is a slide I took from the county director of Murang'a, the Murang'a County. She's called Dr. Kanyi, and she teased out some of the challenges facing healthcare in Murang'a County, and I guess by extension in the whole country. And you can see infrastructure is number one. We say some of the county facilities need upgrading of several facilities, including the maternal child health care system. There's a disease burden of non-communicable diseases of hypertension, diabetes, cancer, and there's a need for mapping of diseases at a community level. And of course, human resource for healthcare, which is at the bottom of my heart, and specialist units like ICUs are needed. That county director of Murang'a just summarized the whole spectrum of health problems or issues, as it were. They're actually not problems, challenges which have solutions in a very simple slide. So medicinal technology encompasses a wide range of healthcare products that are used to diagnose, monitor, and treat diseases and medical conditions affecting all of us. So we group these medicinal technologies broadly into medical services, information technology, biotechnology, and healthcare services. In that context, sustainable healthcare, how do you say that a system is sustainable, how that the healthcare system is sustainable? A sustainable healthcare, so I sort of figured it out to be a system that delivers high quality care, and not high quality care that is often left out in services when we are talking of, they call it African places. Improved public health. Note that Private health will improve on its own. It has its own sort of regulatory mechanisms and sort of standards. But if you improve public health, then the healthcare becomes sustainable without exhausting natural resources, and therefore you'll find where do you get the money to sustain health, and without causing severe ecological damage. So my proposed approach to healthcare through medical technologies is to implement through caregivers. The caregivers are the people who are in touch with the patient. The caregivers are the people who know the problems with the system, and the caregivers are the ones who can make the correct recommendations on what needs to be done. The caregivers, though, may be biased in their field. Therefore, over and above the caregivers, you may tell them to do a needs assessment for you to be able to know what needs to be done to to maintain sustainable healthcare. And therefore, medical technologies are just a way of bridging the limitations between the healthcare provider and the patient. So my approach to this system is to have accurate data collected by the caregivers and doing a needs assessment. Once you do a health assessment and listen to the caregivers, then you feed this information into an ICT system, which is another medical technology. And the information generated is the one that is used to decide on what is the most suitable medical technology to use, as opposed to a push kind of way. Then you generate a policy around those needs that have been generated by the needs assessment and the medical workers. And then you engage the suppliers to ensure affordable, sustainable supply of the technologies. And once you have identified these technologies, then you recruit, train, and health workers and retain them for them to continue using that medical technology so that the health is sustainable healthcare. So I'll use a few examples of all those things I've said before. We'll start with my area of interest, obstetrics and gynecology. You have at Murang'a Maternity, where I work, a 26-year-old first-time mother comes in and she's due for delivery, she's not in labor, and she says her baby is not playing. Her pregnancy has otherwise been normal. That is the biggest nightmare for a gynecologist. Baby not playing, mother not in labor. And so in the public sector, if you are in Aga Khan, there was a presentation by Aga Khan, they will put you on a cardiotocogram. A cardiotocogram is a machine which you place here, and the baby tells you that I am dying, I am not dying. But in the public health sector, there is no cardiotocogram. You get it? Therefore, but now for the patient, without the use of the cardiotocogram, what we do sometimes, maybe I should ask a doctor what they will do in this one. Who is a doctor? What would you?
Fetal heart rate on a regular basis.
Fetal heart rate, how regular?
Well, I'm not a gynecologist, but at least depending on the condition of the patient, if there's tachycardia, you need to be more frequent.
Yeah. The problem with this is that a baby who stops playing gives you 3 days to die. You get? So you don't know when they are dying. Meaning that, let me use a good example. For instance, if you have compromised a tight fetal heart cord around the neck, the baby will stop moving, but the heartbeat will be very nice, but you don't know when they'll die. See, so they usually in the public sector, when you don't have too much things, you proceed and do a cesarean section, yeah, or you'll do an ultrasound. You are trying to decide. You know, it's difficult, the decision making. So you do a cesarean section. Why? If you don't do, the baby will die. But there are conditions where, in this situation, the mother does not need a cesarean section, yeah, and the determination of that is using what we call a cardiotocogram. So my innovation in this is to get a mobile cardiotocogram. Just there are some machines I have seen, and I want to start implementing some at Murang'a County Hospital. Put the cardiotocogram, carry it around. It's a machine that can be used for many mothers. It's a machine that it's a one-off, you buy it. But now over and above the cardiotocogram, connect it to a system, which maybe it transfers it to a phone, maybe the doctor, the gynecologist has it on his mobile, like an app, and then he can read and tell the person, whoever it is, even if it's a far off place, that do a cesarean section, deliver by induction, you see. So this invention is a mobile medical device that can save the mother from an unnecessary cesarean section, and it will also reassure the health worker that the decision they are making is right, and it is not expensive. So for the businessmen, as he said that your bill, people are deciding, are they on the profit side or are they on the loss side? This one benefits everyone. The businessmen now come in, we tell you, suppliers, this mobile cartographer with a software application which will help both the mother preventing unnecessary cesarean section and the doctor knowing definitely that this is the right decision that you're making, and it's sustainable. That machine will be there for the next 20 years once it's bought. And it can be taken down through to all like health centers. Even the midwives could use. You just do a training session on that. That's an example. Okay. Gynecology again, sorry, I'll be short in this. Colposcope. We have been saying cervical cancer is killing women, yeah? So we want in the bush there, you do not have enough gynecologists, you do not have enough doctors. So at the community level, you have the health centers where in the national program, we are doing what we call visual inspection. But the nurse at the health center puts the speculum, sees something that is not cancer and it's not normal, you see? And she can't make a decision on what it is. So the usual pathway for this 48-year-old lady who presents for cervical screening, she's not sick, and the nurse looks at the cervix and says, this is abnormal, but she doesn't know what it is, needs higher level. So what happens to the patient is that we remove the speculum, you get her to take the first bath. This Kangema is 30 minutes from Murang'a County District Hospital, which is where the gynecologist is. Take a bath. Now come out of that position, which women don't like a lot. Take a bath. Now go and get a repeat examination at the general hospital. And now, so my thoughts of this is that that woman does not need a repeat examination. She does not need to travel to see the gynecologist. So get a colposcope. A colposcope is a machine that can actually see, take a photo, transmit to the gynecologist. You see? And then so say, hey, what's this? We say, yeah, we've seen this before. So that sustainably, the colposcope has been bought once for that facility. Yeah? And it's a mobile, it's like a phone, you know? Actually, you have colposcopes with the phone. So you take the phone, send it to the gynecologist, tells you, yeah, this is there. So you have saved the mother from transport, you have saved the mother from anxiety of not knowing whether she has cancer or not. You have saved the unit where the colposcope is earns money, as opposed to transferring the money to another hospital, which does not deserve that patient. That patient's money is in that. Yeah. So that's how we need to start thinking around medicinal equipment for sustainable healthcare. A one-off buy. Now, the businessmen, when do they come in? Get these colposcopes, sell them all over. How many counties? 47 counties, 130 hospitals, 2,000 health centers. That's where the businessmen come in. So no one loses in this because usually we are fighting between businesses and service. Yeah. Okay. Good. At the casualty, Murang'a Level 5 Hospital, a 46-year-old diabetic male is wheeled in. He complains of chest pain radiating to the upper arm. He is short of breath. Yeah? Immediately you are thinking, wow, myocardial infarction. Now, myocardial infarction, when you go to, for instance, maybe a public health, the doctor will say, ECG. There is no ECG. There is no ECG machine. Or if there is an ECG machine, no one knows how to interpret it, you see? But this man is a 1-second person. He'll fall and die. So you need to make a decision on whether to refer or treat the patient. Normally what we do in what we call apartheid medicine, you give him everything, Johnny, aspirin, oxygen, but you have not made a diagnosis. You know, there are types of maybe the people who are physicians. Yeah? So if you had an ECG machine that transmits the signal or the reading to a doctor, wherever they are, it doesn't matter, on his phone, then this person would make a decision on whether it is ST elevated, myocardial infarction, therefore refer to a facility, or treat. You get. So that way you have sorted out this guy. The blunderbuss way of going to do this, you kill more patients because you have no diagnosis. The businessmen now, please buy ECGs with software so that you can transmit information. So this is sustainable. The machine has been bought once for that facility. It is used to save life because myocardial infarction, you don't want to start gambling with whether a person has ST elevation. Do we give him junior spiritual? And software. The software companies have a program which can interpret. Yeah. So everyone benefits, and that's sustainable healthcare. The patient is alive. The businessmen are rich. They are selling ECGs. The software guys are employed. They are writing. Yeah. So that's the way we need to go. Orthopedic implants. In the surgical ward at Moranga level 5, there are 100 men just looking at the wall. You stroll in the ward, you find people on traction for fractured femur because they fell on a motorbike. Now, part of the problem is that there are no implants, or the implants cannot be found. So we want the businessmen to pitch camp in our counties and sell implants. Part of the problem is that the implants may not be there, may be expensive. Yeah. So a study conducted at Murang'a County Referral Hospital by Dr. Wangari Ng'ang'a showed that the saving of ORIF, open reduction and fixation of fracture, is so high for both the NHIF, let's say, and the patient in terms of time spent out of hospital. It's so high that there is no reason why people should be on traction. Yeah? So we want the implant people to be selling implants, and we have implants fixed so that we don't have full wards of people on traction and things like that. Yeah? Probably. That's what we need a businessman. All right, Murang'a level 5 now for the pediatric unit. A newborn is delivered at 33 weeks gestation, that's a preterm, and is admitted to the newborn unit with complaints of fast breathing, chest indrawing, and extremities. The pediatricians are in trouble. They know if you are in Murang'a, what is all this? Because the treatment for this is where are those doctors? They are not doctors, they are only administrators. Okay. Oh, what's the treatment for this? Preterm delivery with respiratory distress.
So you need to go for the
neonatal ICU, yeah, in Murang'a there's none. We are talking of the county.
You need to refer the patient to who can manage.
Refer, yeah. Intubate, you're saying intubate, yeah? Yeah. But one of the continuous positive pressure, CPAP, something they keep saying in medical school, but when they go to the ground, they don't bring it. And I discovered the other day, in fact I used to think it's a big thing. It's a very simple thing. So we need businessmen to come in county hospitals, send this CPAP, and it can be moved. And once you have purchased it, so you have saved this baby because they unless you, surfactant actually is the treatment for this because the lungs are not, but surfactant very expensive again, may not be available and things like that. So CPAP machines are the technologies that you need to be camping in the counties to sell these businessmen. There's so much money to be made from these men. And everyone will be happy. The baby will be sorted out. The pediatrician will be sorted out, or the doctors. The hospital will improve its ratings in terms of deaths of babies. You get. So these are simple things that we should not be talking about. We should actually be applying. But the businessmen will also be happy. Intravenous iron. We are saying there's no blood. No blood, no blood, no blood everywhere. The company should be, so Jane is a 36-year-old, she has no child, she's been having heavy menses, her hemoglobin is 4.5. She needs an operation, but there's no blood. But we know that intravenous iron actually raises the hemoglobin. So why don't you sell intravenous iron to make it part of the essential drug list in government facilities or for the government? Yeah. So anyone, you sell many ions. You don't need to sell them a lot of iron. The patient will be given iron. Her hemoglobin will go to 10. We operate on her, remove her fibroids. She'll get her baby, and everyone is happy. That's sustainable healthcare. ICU HDU in Moranga, A&E are 48. If you are knocked down, a gentleman knocked down by a vehicle and he sustains a head injury, a CT scan shows that he needs an operation, and after that, of course, after head operations, you may need ICU care for a day or two. There's no ICU, there's no HDU in that place. Yeah? That's one of the examples which I want to link with. Yeah, ICT software. This is what we are discussing with that many women with symptoms, we have noticed, we have been doing a lot of operations, and traditionally they have been telling us, oh, women without children get fibroids, that's if, but at Moranga County Hospital, anecdotically, we have seen women with 5 children have fibroids, and big ones at that. So what we are saying, there's a knowledge gap. There's the assumptions that we had previously, we are not able to collect this information and say that, no, this fibroid also we think is from food, you see? So if we had a resource base, a resource center where we are collecting all this information on all the patients we are operating in, then you can analyze and say, all the women we have done fibroids in, they live in Keriaine, that Keriaine place has a lot of mercury, and therefore mercury is causing fibroids. You get the point? So we don't collect our information enough. So there's a gap, a resource center and some software for collecting data and analyzing it. Yeah. I'm almost sure that the battery is. Okay. Now to previously, there was a 19-year-old girl who comes with an ectopic pregnancy. If you're in Moranga, what do? We do open laparotomy. For those who know, we just open, pick out the ectopic, pit out the ectopic, and save her life, and she goes home. If you come to the city, there is something called laparoscopy, where, minimum, we put 2 holes, 3 holes, like that. And so there is a huge gap in laparoscopic technology in the district. So setting up a laparoscopic unit is very simple. In fact, I've done a calculation of it, probably 4-5 million max, and you have had your training. So we need a businessman, someone to come, carry the laparoscopic equipment, go to all the counties, now that we are looking for universal health coverage. What's the benefit of that? We don't cut up our ladies. The recovery time for hospitals is a day or 2, as opposed to where you have an open laparotomy. And it is sustainable because you're improving skin and improving them. Then, now in Moranga, what we are saying is that there is a private hospital there that could actually set up laparoscopy. They don't have the encumbrances of public sector where you have to go through the government all the way back down. So if they do a laparoscopy unit, for instance, and an ICU, the one I alluded to, 2-bed, you don't need too much. Then they could link up with the public hospital to be referring their patients there, and you sort out the issues. Currently, you'll have the ICU patients referred to Kenyatta National Hospital. There is no bed. So by the time they're in between there, they have laparoscopy, then you have all ladies with big scars, and that's not nice for them. So let the private facility take up the opportunity in these medicinal technologies to set up an ICU, laparoscopy, and that will help in sustainable healthcare. So finally, the approach to sustainable healthcare through medicinal technologies must be seen through the eyes of the caregiver. Why I came up with this is because the current health system is that we are having push medicinal technologies. They have bought CT scans. They are just waiting. They tell us we need actually the MRI was the best one. The MRI. You know, they brought for us MRI, so now you are starting to wonder. Previously, no one had ever had an MRI done, but now all of a sudden, MRI. If they had asked the caregiver, the current CT scans would probably have come fast before an MRI. MRI is very specialist. So the bottom-up approach. The bottom. Hello? No electricity? The bottom-up approach is efficient and effective in the use of resources. It is evidence-based as it collects accurate data. Collaboration between all players, and we saw private and public, in the health ecosystem is very necessary. And this is how you tailor medicinal technology to sustainable health services, by involving the caregiver. Okay. Finally. So in summary, this is the summary of medicinal technologies for sustainable healthcare. How do you look at it? You base it on needs. Do not do a push thing. Base it on needs. Ask the caretaker, what do you need? You use them optimally. You make sure that it is locally owned, and make sure that the community also owns it. Make sure that the technology is easily transferable, that the technology is not dependent on that one big doctor like me, the gynecologist. Only when the gynecologist is there can you use this machine. No, it has to be easily transferred. Everyone, from up to the health, the nurse, everyone, the bottom line of use should be able to use that technology, not reliant on an individual, and it benefits both the patients and the users. And the benefits can be both monetary and non-monetary. What people tend to forget is the non-monetary benefits, for instance. For instance, if we start in my department using a cardiotocograph, then we will become, with time, experts in cardiotocography, and we will give input to how to improve monitoring of labor in mothers. And that knowledge makes that doctor a resource person, you see. So people must also look at that aspect of the non-monetary. But also the monetary ones is not bad. People don't like paying doctors. That's the problem. So I think doctors should be paid for work done also. Right? And with that, I think medical technologies for sustainable healthcare, we've done. Mumtaz Mahal was the second favorite wife of surgeon. Now, she died delivering her 14th baby. She probably had obstructed labor. If she had used medical technologies, I think she would still have survived. Unfortunately, we would probably not have the Taj Mahal. So where she is buried with surgeon, and the daughter who was actually delivered was also buried in the Taj Mahal. She lived to 74 years. Thank you very much. I was running away from the question. Yeah.
Okay, we'll take one or two questions now from the audience. Just to say, if Mumtaz Mahal used a contraception, she wouldn't have had such a
That's also medical technology.
So, if you can indicate possible question.
I had a very great talk.
Thank you.
I think there's another component to that, the element of telemedicine, that it combines across these technologies. So you can, communicate as well. Take the expert advice when you also have the device. For example, a CPAP machine. Keeping a CPAP machine in a county, you cannot go more than 24, 48 hours. It's difficult unless you have trained the local person there. So you can use the CPAP machine to transfer to a unit ICU. So that again, telemedicine helps a lot. Managing the CPAP machine there. So that makes a lot of difference. So combining telemedicine, which is today very easy, video conferencing even through Skype, you can